Good afternoon, and thank you for turning up. And I hope we'll have enough voices of the consumers from the floor if we don't have our third person here. I'm here to talk about the UK policy environment and context. And I'll start off with a little explanation of what ASH is, and also explaining our funding. ASH is a British NGO dedicated to reducing the harm caused by tobacco. We were set up by the Royal College of Physicians, which is an eminent medical body in the UK, in 1971. Our role is advocacy, networking, working and information, and really importantly, we are anti-smoking and not anti-smoker. We receive core funding from the British Heart Foundation and Cancer Research UK, and we've received funding from our Ministry of Health for work to support the implementation of the government's tobacco control plan. We don't get commercial funding, we don't accept funding from the tobacco industry, the pharmaceutical industry, or the electronic cigarette industry either, for that matter. This presentation, well, I'm at this meeting on behalf of the Framework Convention Alliance, and as I said last night, for them I'm here to listen, because the Framework Convention Alliance, which is a coalition of NGOs around the world, over 350 now organisations in over 100 countries, which is dedicated to the development, ratification and implementation of the world's first health treaty, the Framework Convention on Tobacco Control. That organisation develops its positions by consensus, and as yet we don't have a position on electronic cigarettes. It's under discussion. And I've come to this meeting to hear what people have to say and to feed that back into the process of the development of the FCA's position. Oh dear, do I want changes? I don't think so. That's really undermining me. Yeah, so that it hasn't got a position at the moment, but I'm here to listen and take back views to the Framework Convention Alliance. So this presentation is on behalf of ASH, not the FCA, and the views that I'm expressing today are views of myself and ASH, and not of the FCA. I'm talking about the position in the UK, and in particular in England, and that may be a bit parochial, but it's what I know best. And also, I'm talking about it because I hope it will be helpful to other people. We've been working on tobacco harm reduction in the UK for a lot longer than in many other countries. When I started in 2003, it was already an issue which ASH was engaging with. And when I started, one of the first things I did was to meet up with the MHRA and to discuss the regulation of NRT, which was quite strictly regulated in those days. And we worked hard with the medicines regulator, and the really key change that they made was that they thought hard about what the purpose of NRT was, and they came to the conclusion that they should regulate it in a much more liberal way than they do other medicines, because on the basis that there are no circumstances in which it's safer to smoke than to use NRT. So when you're licensing medicines to the medicines regulator, the comparator is usually placebo. They began to realise that actually with NRT, with nicotine replacement therapy, you need to think that if people are not using that product, they're likely to go back to smoking. And that completely changes your risk analysis. We also encourage the government support for a harm reduction approach. My first job when I came to ASH was to get smoke-free laws in place, and we succeeded in that in 2007. But at that point in time, lots of people were saying, oh, well, tobacco's done, we don't need to worry about smoking anymore. And yet, in England, 80,000 people were dying each year. In the UK as a whole, over 100,000. And so we worked together with other organisations to develop a report looking at what government needed to do next to reduce the harm caused by tobacco. And in 2008, we published a report called Beyond Smoking Kills, which was endorsed by over 100 public health organisations. Had a wide range of recommendations. I can't remember how many there were, but over 40. But I won't go through all of them. I'll only go through the ones on harm reduction. And just to mention that one of the key recommendations was that tobacco should be put in standardised packs. And you may have noticed that on Thursday, the UK government said that it was bringing forward regulations on this. So, you know, we've moved on that. On harm reduction, we're still in development, I think. And the principles that were endorsed by those 100 public health organisations, and it involved a lot of debate and discussion, because tobacco harm reduction, as you will know from your own countries, is a contentious area, were that we wanted government to support the development and use of alternative pure nicotine products for smokers unable or unwilling to quit. And it's important to note that while this was after e-cigarettes had first gone on sale in the UK, it was at a point in time where they were also almost unheard of, to implement a communications programme to counter public misunderstanding of the health impacts of nicotine, because we knew that a large number of smokers actually thought that nicotine caused cancer. And not only smokers, but many doctors were saying that to their patients too, that nicotine was the offending substance and not the smoke. To encourage the commercial development of products and tax at the lowest rate, so that there would be a price incentive for people to switch from tobacco, which is very heavily taxed, to lower taxed, safer products. To evaluate the cost effectiveness of provision on prescription and increase investment in research into nicotine, and to regulate the market either by a new authority or within existing structures. And we looked at a number of regulatory options in 2008, and we looked at the pros and the cons, and you can see we looked at medicines regulation, and we recognised that while there were potential benefits, there are also potential risks. Food regulation was clearly not a runner. Light touch regulation, for example, by the Department of Health, well, there were problems with that because you're talking about setting up a new regulatory body at a point in time when certainly our government was not interested in setting up new regulatory bodies. Or retain the current situation. Change might be quicker, no regulatory costs, but a lack of clarity about the regulatory position, a lack of control and monitoring. And to date, and I'm talking about 2008, that approach had not encouraged well-funded new entrants to come into the market. Now, we all know that an awful lot has changed since then. The world is a different place. We've seen a massive growth in use of electronic cigarettes, not just in Britain, but worldwide. And electronic cigarettes, I remember going to the first launch at the Gala Casino in central London of the first electronic cigarette, I'm saying, in Britain. And it was, you know, a real minority product. There were a few people there, and there was an E-list celebrity using this product who kept saying, it's fabulous, it stopped me smoking. And they were trying to shut him up because they knew if it was being marketed as something to stop you smoking, it immediately became a medicine. At that point in time, many thought it was just a fad. We didn't mention it in Beyond Smoking Kills because not enough of these products were being sold for us to think it was a realistic alternative. And it wasn't mentioned by the Royal College of Physicians in their really important report in 2007 on harm reduction. But by 2010, things had already begun to change. We tried to persuade Robert West at UCL to do research on electronic cigarettes in that point in time, and he wasn't interested. So we went off and did our own research, and we set a baseline. We do an annual survey of not just smokers, but the general population and their attitudes and behaviour every year. And we asked the first question about electronic cigarettes in 2010. And we also did some qualitative research, going out and asking users themselves, users of electronic cigarettes, what they thought about them, what their concerns were. And use was still tiny then, but by 2012, our survey in 2012 showed that if you grossed up the percentages of smokers using these products at the population level, you already had 700,000 people using them. And that rose to 1.3 million in 2013 and 2.1 million in 2014. And we've seen since then the tobacco industry's moved in, the pharmaceutical industry hasn't. So if we look at this in percentage terms, in 2010, of those currently using e-cigarettes, and that's smokers, it was 3% in 2010, it's now 18%. Many more have actually tried electronic cigarettes, 3 times as many in 2010, and slightly less than 3 times as many in 2014. And sustained use amongst adults is confined to smokers and ex-smokers. And I won't go into this in detail because you all know that that's the case. The other thing that's interesting is why are people using them? And Clive in an earlier session said, people aren't using them to prevent them from smoking entirely. Well, that's not our finding. Actually, when we ask adults who report using electronic cigarettes, and they can answer more than one of these, so it doesn't add up to 100%. But by far and away, the most important reason why smokers are using these products is to help them stop smoking entirely. The second most important reason is to help them keep off going back to smoking, so to prevent relapse. And the third most important are to save money and to help me reduce the amount I smoke, but not stop completely. Children is the other area. There's great concern about a gateway effect. Well, we started doing research on children in 2013 when that first became a big concern to people, because it was obvious there was no decent surveys being done. And our survey then showed that almost no children use cigarettes, electronic cigarettes, who haven't already been smokers. We're writing up the 2014 data for publication, so I haven't included it here. It shows a very similar trend, but more children are trying them. But the other important point is, people argue about the gateway effect. Well, if people start using electronic cigarettes and then they move on to, children start using electronic cigarettes and then they move on to smoking, isn't that evidence of a gateway effect? Well, no, it's not. If you look at teenagers, then those who experiment with risky behaviours experiment with all sorts of different risky behaviours. You know, if they try smoking, they're also likely to engage in unsafe sex. They'll be drinking, they'll be trying illegal drugs, and they'll be trying electronic cigarettes. Just because they do one before another doesn't necessarily mean that it's a gateway. The only real way to tell whether there's a gateway is if smoking prevalence begins to go back up again, and we're not seeing that either amongst adults or amongst children. This only goes up to 2012 because it's ONS data, National Statistical Office data, but Robert West's survey, which goes up to much more recent times, the last few months in 2014, show the same trend continuing, that smoking prevalence in England is going down, just as electronic cigarette use goes up. So what are my conclusions from all of that? Well, there's been a massive increase in electronic cigarette use. There's no evidence of regular use by never smokers or children so far, but only around 1 in 3 of those who are trying electronic cigarettes carry on using. And people say, oh, the products have got so much better. But that proportion is not considerably different in 2014 than it was in 2012. So if the products have got so much better over the last couple of years, you'd expect that to change. And of those, only 1 in 3 have quit smoking entirely. 2 out of 3 carry on smoking too. And that's not the best outcome for people's health, to carry on smoking too. Plus, we've got a rapid growth in marketing that's causing massive concern. And just because it's not a gateway yet, doesn't mean it won't be. And we need to do everything we can to prevent that from happening. So my conclusions are, these products are not a magic bullet, and that we still have concerns about potential youth uptake, and regulation needs to take those factors into account. So in 2010, the UK position on tobacco harm reduction was that we had a government strategy published which publicly acknowledged that harm reduction using admittedly licensed nicotine products and medical products was a good thing. But the important point is that our government acknowledged that harm reduction for tobacco is a positive. And the medicines regulator in that year licensed NRT for long-term use, saying, you know, we don't care if people carry on using alternative nicotine sources for the rest of their life. It's going to be less harmful than smoking. That potentially brought electronic cigarettes within the regulatory remit. Because electronic cigarettes escaped medicines regulation because basically they were being marketed as an alternative to smoking rather than as a way of quitting. But once actually the medicine's license was for products to be an alternative, then potentially they could be brought within that remit. So the MHRA, our medicines regulator, consulted on options, and the options were to regulate and take off the market, regulate and allow time to comply, or do nothing. And at the same time, NICE, and Linda will talk about this, which is our public health organisation which produces guidance on public health issues and also clinical guidance for doctors, was commissioned to provide guidance. The position's evolved since then with what's happened on the TPD and everything else. So in 2011, the MHRA, the medicines regulator, announced more research needed, but that it wouldn't take electronic cigarettes off the market while that was going on. In 2013, it announced it would regulate, but not take electronic cigarettes off the market until the TPD was implemented. In 2014, after the decision was taken to bring electronic cigarettes within the TPD, it said, well, basically because of that, we're not going to take them off the market, but we're still trying to encourage companies to bring their products forward for medicines licensing. And there are 2 products going through the process. The MHRA's position is it wants to support the availability of safe, effective, good quality products for smokers. So I'm sure we'd all agree with that. The question is, can they do it? And can they do it in a global environment which is very much more difficult for electronic cigarettes than the one we face in England and the UK? Out there is no level playing field. The US will regulate as a tobacco product. What exactly that means will remain to be seen. In Europe, we've got this twin track approach. So from 2016, products will either be consumer products regulated under the TPD, or they will have to get a marketing authorization as a medicine to be allowed to be on the market. In Canada, we've got personal consumption legal, but sales banned, and products being widely used. But as Clive pointed out this morning, both in Canada and Australia, which has a similar process in place, as a result, the market for electronic cigarettes has had a chilling effect on it, and it has not grown as rapidly as it would otherwise do. And in low and middle income countries where, as Takin pointed out this morning, we will see the majority of deaths from smoking in the 21st century, in a lot of these countries it's already banned. Brazil, Hong Kong, Malaysia, Turkey, UAE, still legal in China and India, but who knows for how much longer in India. And lots of other countries are considering banning electronic cigarettes. South Korea, it's legal but heavily taxed, like tobacco. And WHO is examining regulatory options. So it's a very uncertain environment out there. I'm just going to talk a bit about the EU regulatory framework, and in particular just point out why we think there are some potential benefits to medicines regulation at an EU level. Under the TPD, advertising will be banned, tax will be 20%, upper limits for nicotine content, health warnings on packs, you won't be able to make health claims, won't be available on prescription. Whereas under medicines regulation, you've got much lower tax, certainly in the UK, and that's potential for other EU countries too. Advertising will be allowed, restricted, have to be advertising aimed at adults, not at children. You can make health claims. The regulation is flexible. There won't be this upper limit, and no health warnings on the packs. Our position is that policy and regulation should be evidence-based, that the regulatory framework needs to be consistent, because that's what's going to be best for electronic cigarettes to work effectively in the future. And the regulatory framework should support quitting completely. It will always be the best outcome for smokers. If they want to carry on using, fine. But we need to carry on supporting smokers who want to quit. Ensure easy access for smokers. Restrict marketing to adult smokers only. Prohibited marketing that promotes smoking-like behaviour, which is what the health community is really concerned about, because that's what they think will lead to the gateway effect. Facilitate communication of accurate information, particularly on relative risks. Encourage improvements in quality, safety and efficacy, support innovation, and monitor the market and be responsive as it evolves. Because as we've seen over the last couple of days, this is a rapidly evolving market, and we cannot think that a regulatory system that is fit for purpose today, even if it is fit for purpose, will necessarily be fit for purpose tomorrow. And we'd like to see the UK setting the standard for effective regulation in Europe and worldwide. Will medicines regulation be beneficial or not? Well, there are arguments for and against. We've all heard the arguments against. I'll just add the arguments for, and this is something called the Porter hypothesis, which has been used for environment regulation, that regulation can actually trigger innovation, making production more efficient, and lead to cost savings which overcompensate for compliance and innovation costs of regulation. Now, these are hypotheses, just like the hypotheses against medicines regulation are there. But it is possible that that's the case if regulation is implemented in the right way. And in addition, you have the reassurance of quality and safety to smokers. And we should not just be worried about the vapers in this room and in this conference. We need to be worried about the vast majority of smokers who aren't using these products. And when we ask them, one of the things that most concerns them is quality and safety. And you can say, oh, well, that's all the problem of people who are complaining about these products and don't understand. It doesn't really matter. At the end of the day, if those smokers are going to be encouraged to use these products, they have to feel that they can be safe and that the quality is good. In Europe, the twin track approach gives producers and consumers choice about which market they're in. The UK has made a commitment to make medicines regulation work. It hasn't proven it yet because we've not seen any licensed products. They've got to make it work, and we will do everything we can to bring pressure to bear to make the regulatory system fit for purpose. We expect there will be UK licenses soon. It's an opt-in model, so the proof at the end of the day will be whether manufacturers opt in or not, and whether licensed products are popular or not. So, what should regulation achieve? Well, my view is, and this is very broad brush, maximum benefit, so to encourage switching, support quitting, discourage relapse, and minimum risk by discouraging uptake amongst youth and discouraging uptake amongst non-smokers. And that's it.
Okay, so please, right now.